beautiful countries in the world, India and Australia. This is eCritCare Podcast about evidence-based critical care medicine, helping you to save lives. Here are thoughts on controversies in critical care. And now, here are your hosts, Dr. Swapnil Pawar from Sydney and Dr. Jose Checo from India.
Welcome to eCritCare Podcast. This is our episode number 116. And today I'm joined by my two co-hosts, Dr. Jose Checo from India and Dr. Ian Seppel from Sydney. Welcome, Jose, and welcome, Ian.
Hi,
Thank you very much, Swapnil. Jose?
This is very interesting episode for me because today we are going to dive into one of the recent controversy around steroids in community-acquired pneumonia. And this controversy has kind of surfaced after the recently published randomized controlled trial called as CAPE-COD trial. As we all know, the cornerstone of treating patients with community-acquired pneumonia is really early and appropriate antibiotics. And for several decades, clinicians wondered whether the inflammation plays any part as a part of the severe disease profile in community-acquired pneumonia. Initially, corticosteroids became part of the treatment, but soon they faded away after some trials and recently published meta-analysis of 16 trials, which involved 4,000 patients, which did not show any benefit with corticosteroids in patients with community-acquired pneumonia. So there was a consensus that steroids don't work in community-acquired pneumonia. In fact, American Thoracic Society guidelines published in 2019 suggested not to routinely use steroids in community-acquired pneumonia. However, after the publication of adrenal trial, the steroid use became quite prominent if patients with pneumonia come with a septic shock. We are going to dive into this controversy, and I got Jose and Ian here. So first of all, both of your views on CAPE-COD trial and what do you think of this trial? And really the question for bedside clinician is, should we change the practice based on this one trial?
So I'll start. I certainly found CAPE-COD intriguing. I just want to come back to the context in which this was done. So this was a trial designed around about 10 years ago and recruiting in the pre-COVID era in France. And it was actually terminated early, partly because of the advent of the COVID pandemic. And the same researchers switched their efforts to the CAPE-COVID trial, which was published in JAMA. So the trial was designed to recruit over 1,100 patients, actually only recruited 800 before it was terminated early, yet it showed quite a spectacular mortality benefit. One of the things that I find intriguing about this study, so there was almost a 50% relative risk reduction in mortality from 11.9 to 6.2%. That's the sort of thing that we dream about in intensive care trials. And we'll do sort of 7,000 to 8,000 patient trials looking for smaller mortality differences than that. So I'm just a little bit concerned about how spectacular the mortality difference is in this cohort, which in fact is a less sick cohort than we used to be treating. And it's also less sick than the original trial design was planned around with a lower mortality. Certainly, we can't dispute the findings of this trial, but I think we just need to be careful. These patients were in one wealthy Western European country at one period of time pre-COVID. I'm a little bit concerned about the widespread extrapolation of these results, especially to countries with a very different epidemiology of community-acquired pneumonia in terms of the microbiology, and also with risks such as the reactivation of latent infection, which is not really an issue in France, but tuberculosis or with the use of steroids in COVID, we found that in some countries, increased incidence of mucormycosis, for example, with very liberal use of steroids. So we just need to be a little bit careful about extrapolating this into other environments, particularly with some very impressive, slightly concerning mortality difference, which we see in CAPE-COD.
What's your thoughts, Dr. Checo?
I agree with what Ian was saying just now. The study was actually predicted to have a mortality of 27% in the control arm. but the actual mortality was only 11.9%. So it may not have been powered to be able to detect a mortality difference to begin with. And of course, they did not obtain the sample size that they had projected of 1,200 patients or so because of the COVID pandemic. They had to interrupt the trial. So that was another problem with it. And to me, most importantly, is the fact that they did not really look at the etiology, the pathogen that caused the pneumonia, whether it was bacterial or viral. Could you extrapolate the results to bacterial and viral pneumonias as well? That's another important point for me. Of course, we saw during the COVID pandemic, especially with the recovery trial, that dexamethasone does help improve survival. And although previously with influenza in general, observational studies have not shown any improved survival with steroids, during the COVID-19 pandemic, we saw dexamethasone does help through the recovery trial. So it might make a difference as to whether you're treating bacterial pneumonia or viral pneumonia. And then, of course, at what stage do you treat them with steroid, if at all you are going to think along those lines? What is the degree of severity that you consider to be appropriate for treatment with steroids? So to me, the answer is we are left with more questions than answers, really. And you really need to look specifically at some of these important subgroups of patients who might possibly benefit. Of course, there is strong rationale based on whatever small randomized controlled trials existed before the CAPE-COD and the ESCAPE trials. And meta-analysis have, of course, been carried out with conflicting results at best of times. So I would say even in spite of the what looks like stunningly good results of the CAPE-COD trial with a reduction in the 28-day mortality, reduction in 90-day mortality, reduced rates of intubation, reduced rates of vasopressor use, I think we still need to explore further. We really cannot come to any firm conclusions based on this trial alone.
Yeah, this is kind of fascinating debate for me because I guess we got a randomized controlled trial, which was relatively well conducted with all the caveats, but the patients were well matched at the baseline and a large number of patients were recruited. Even the 800 patients is quite a significant number. Follow-up was nearly complete with a loss to follow-up was only 2 patients in the study. And study did exclude the patients with septic shock because we kind of know from the adrenal trial that steroids do benefit in patients with shock. So I guess given overall inclusion-exclusion criteria, I think the trial did perform well. In fact, 44.9% of the patients were actually ventilated. So the trial did include sicker cohort of patients with pneumonia. And yes, I agree with the debate over the etiological agent was not known, so bacterial versus viral pneumonia. But from the COVID, again, it might be extrapolated that viral pneumonia do tend to respond to steroid. Now, the other interesting finding with the trial is authors managed to recruit patients within the first 15 hours of ICU admission. So randomization was done relatively within the short period of time. So again, there was no argument saying that steroids were administered later half of the course so it's really kind of puzzling for me as a bedside clinician why not to follow these results and empirically give steroids to all patients who come to the door of ICU, especially when they're on NIV support or high flow support, and why not to choose hydrocortisone. And the dose is really a stress dose steroid. It's not like a immunosuppressive dose of methylprednisolone, 500 milligram for 3 days or something like that. From adrenal trial, we know that steroid dose is really not harmful. So I'm not sure. And that's why I'm trying to be devil's advocate here. Thoughts?
Could I take you up on a few of your statements? Certainly, I agree with most of you, just what you've just said there. We need to be careful not to overstate what other trials have said. So, for example, adrenal did not show a mortality benefit. That was its primary endpoint. It did show benefits at some secondary endpoints. There's no doubt that in septic shock, hydrocortisone is catecholamine sparing, decreases time on catecholamines and doses, decreases some time on the mechanical ventilator. and time in the ICU. So there's some positive secondary endpoints, but it was actually a negative trial looking at the primary endpoint. So we need to be a little bit careful saying, oh, there's a clear benefit to steroids, because it's not quite so clear-cut in septic shock. Certainly following both that and the French approach trial, I think steroids have crept into practice a lot more, and people who perhaps weren't using steroids in septic shock prior are now doing so. Even the choice of drug is not entirely clear. Certainly, we're not going to use high-dose methylprednisolone, as you said, Swapnil. But we've got a variety of trials looking at both dexamethasone and hydrocortisone, which actually do have different effects to some extent as glucocorticoids, but especially as mineralocorticoids. They are different drugs. In COVID, we started looking at different types of steroids. And for example, in REMAP CAP, we're looking at hydrocortisone, and then had to stop that with the publication of recovery and the very impressive results of the dexamethasone arm of recovery, which I don't think can be argued about, but that's looking specifically at the SARS-CoV-2 virus as a single virus causing a single disease with very, very large caseload, compared to, as Joe said, community-acquired pneumonia caused by a whole variety of organisms, some of which might benefit from steroids and some may not, but we often don't know at the time of ICU admission. So at face value, yes, I think CAPE-COD will change practice, especially in well-resourced environments. I'm just advocating a little bit of caution, and certainly some of the things that you mentioned at the beginning, we don't really know for how long, nor do we really quite know what dose. We say that 200 milligrams per day of hydrocortisone is stress dose, but it's not really. It's actually a bit more than stress dose. We don't know if there's heterogeneity with patients who have a critical illness-associated adrenal deficiency as opposed to those who don't, responders or non-responders, and all those things that have been previously looked at for steroids in sepsis. So I think there's still some unknowns there. Probably the biggest, as you mentioned at the beginning of this chat, is the dosing and the duration, and we really don't know. Do I give steroids just while the patient is sick? Do I give them for a week? Do I give them with a taper dose, or just stop the drug? We don't know any of that really at the moment.
I agree with what Ian just mentioned, particularly regarding the duration of treatment. If you look at the ESCAPE trial, they were different compared to the CAPE-COD trial in that they continued steroids for 20 days and they tapered it down over a period of time, as against CAPE-COD, who treated their patients with an 8 to 14-day course of hydrocortisone. And also the type of drug, as you mentioned, methylpred versus hydrocortisone versus dexamethasone, we really do not know. It may not be very much different if you give an equivalent dose, but still you're unsure as to what may be the most appropriate preparation in your given patient. So that's another point of possible doubt that still exists that needs to be cleared as well. And of course, in spite of the fact that specifically adverse effects related to steroids in terms of nosocomial infections, in terms of GI bleed and so on, have not been found to be higher compared to the control group, either in the CAPE-COD or in the ESCAPE trials. We still need to be aware of the fact that there are problems with the use of steroids, and they may specifically affect patients who are immunosuppressed, and it may not really come out in a randomized controlled trial.
Can I be devil's advocate in return? That we've gone from the situation that you described in the intro, where we had European guidelines saying to use steroids in community-acquired pneumonia, and American guidelines that said do not. The American guidelines have now changed. So we've now got guidelines both in North America and Europe saying do it. We're sitting here saying, hold on, hang on, quite sure, be careful. Is that position tenable? So this is me being devil's advocate now.
And that's exactly my question is because, see, one of the fascinating aspect of clinical medicine and the interaction with the research is how the behavior change after the trials or don't change after the trials. So for example, ProSeva, when the ProSeva trial came out, 50% mortality reduction after proning. Nobody believed that. Nobody practiced proning as widely as. But in COVID, we saw the benefit based on the experience-based medicine, and then everybody started proning patients left, right, center, and then suddenly we like, oh, that there is a huge benefit of proning, and now everybody prones patient even before thinking of ECMO. The change in behavior after adrenal trial was equally quite remarkable, even there was no mortality benefit. Just because of the 1 or 2 day reduction in the hospital or ICU stay, people prefer to use steroids in septic shock, despite there is no mortality benefit. While now we are seeing the CAPE-COD trial, which clearly showed significant mortality benefit at 28 days, we are using the caution to say, maybe don't use it, or maybe use it only selectively. And I just kind of struggle with that concept of this trial, which shows mortality benefit. We say, don't trust this trial. Trial doesn't show mortality benefit, which we change our practices.
Yeah, it's an interesting approach to, I guess, the human mindset and trial interpretation, as you say. I'm not saying don't trust the trial. I'm just saying to everybody, don't blindly implement this without thinking whether there's external validity into our own patients and our own environments. Are we treating the same patients as those that were treated in France in this trial? And that, to me, I think that's the big question. But you mentioned Proceva. It's hard to prone patients. It's hard. It's hard work. And I think that's why people weren't particularly keen until they had no choice, and they were forced to with COVID. Whereas it's pretty easy to prescribe a drug that doesn't cause me any trouble at all to put a prescription on a piece of paper or on an electronic chart. So we love prescribing drugs. Just being a bit careful.
Yeah, I agree with that sentiment. It's just the interesting factor in terms of we are not going to get another trial compare hydrocortisone versus dexamethasone in patients with community-acquired pneumonia. What do you think as a clinical trialist, Ian? If you are not certain about the results of the CAPE-COD, what should be the next trial?
Well, there are some other things out there. The one ongoing initiative is the massive REMAP-CAP trial, and specifically the non-pandemic, so the non-COVID arm sort of REMAP-CAP, and there is a steroid domain there. So those sorts of big, all-encompassing, very efficient platform trials, I think, do have the potential to answer some of the questions that we're asking, where it's probably not going to be feasible to design a single specific placebo-controlled RCT or something like that, or even drug A versus drug B RCT. But in the context of these big adaptive platforms, there is still the opportunity to answer many of these questions.
Yeah, and I think that's going to be the challenge, isn't it? Because till the next trial is published, which will probably take more than 4 or 5 years to even get running or get the results, we do not have a robust evidence to refute the findings of CAPE-COD trial. And I think invariantly, a lot of people are going to switch their practices to use hydrocortisone 50 milligram QID per day or 200 milligram per day till patient gets better. And that's the empirical duration and dose that we all are going to practice.
In India, I can say that we haven't changed our practice based on this study. And I feel it may not be appropriate either, because we have a different case mix compared to the French population, particularly with the high incidence of TB among our patients. Fungal infections are common. So we really haven't changed, and I don't think we will change based on the evidence we have so far. Of course, there are selected patients in whom you might try. Septic shock is one subgroup, and possibly viral pneumonias if they are severe, and if they do not respond in the first couple of days, if they're on ventilation, they don't seem to improve, we might use it as a last resort. But otherwise, as a general rule, we wouldn't use corticosteroids routinely in all comers to the ICU whom you consider to have severe pneumonia.
So can I ask you, Jose, and this is for my education, in the respiratory wards in India and in your environment,
yes,
are steroids used liberally? Because I'm used to respiratory physicians who treat a lot of reactive airways disease and COPD and asthma. So the majority of patients who might be admitted to the hospital with an exacerbation of COPD end up on steroids and usually and often inappropriately antibiotics. But steroids are used very commonly at that end of the spectrum. And now we're using steroids more in septic shock at the other end of the spectrum. And really what we're talking about here fills the gap in the middle. So it certainly is being used a lot more frequently in Australia. I think whether we like it or not, these patients are being prescribed the drugs. So I'm curious in India at the less sick end. So these are not your patients. These are the patients in the respiratory ward. Are your respiratory physicians using lots of steroids?
I don't think they have changed their practice in the last, say, a few months since we had this new trials. The severe pneumonias of any type, they would transfer them to the ICU, of course, and then we take care of them jointly. And any introduction of steroids, of course, will be after discussion amongst the team members. So in general, I don't think our practice has changed. They wouldn't use steroids apart from the indications that you mentioned as COPD or asthma. Otherwise, pneumonia is admitted to the ward. I don't think they routinely use steroids at all.
To be honest, I have not seen that trend even in my hospital here in Sydney. I'm not sure about you, Ian, but I think the respiratory physicians are not probably aware of this trial that much to change their practices. But it's the intensive care community who is currently on the bandwagon of changing the practice. And I'm seeing more use of steroids by intensive care physicians more than respiratory physicians. What's the situation in your hospital, Ian?
Yeah, I'm certainly seeing more use. I think a lot of this is being initiated in the emergency department because the majority of these patients, I don't really have a choice because the drug has already been started. I obviously don't see the least sick group who are never referred to the ICU, so I can't say for sure what is done there. But it's now becoming, I think, quite common to start both steroids and antibiotics for these patients in the ED. And when we receive them in the ICU, they're already on these drugs.
Yeah, that's interesting. And I think I'm not sure whether the community-wise, even the GPs will probably start doing it in the community now with Augmentin prescribed the prednisolone. And that will be interesting to see how this drug uses creep into the society, I guess. And that will be, I think, really concerning and more harmful.
It'll be interesting, especially if we start seeing shortages again. So there was a global shortage of dexamethasone about a year ago, partly driven by the COVID use. But we're also seeing it used very liberally elsewhere. So being a different hat on in my anaesthetic practice, we're now seeing very liberal use of steroids. There have been trials showing the benefit of steroids for postoperative nausea and vomiting and sort of nausea prophylaxis. I think there are some anaesthetists that now give a dose of dexamethasone to every single patient. It's really quite common. Probably safe. It might be beneficial if you're worried about nausea, but we can think about all the other adverse effects that perhaps aren't so good.
Yeah, and I think definitely the steroid usage is definitely on the increasing overall in the hospital. And there was a bit of protection against pneumonia due to the guidelines in the past. But now I guess with this trial, it's hard to control the use of steroid. And probably we won't see the side effects in immediate time frame. But I guess over the period of time, I think we will be seeing all those collateral damage of the...
That's very true, particularly, with mucormycosis and similar fungal infections possibly, which you won't see immediately, which happens down the line, much further down the line, and your patients may suffer for it.
And I guess that's Ian is studying as a part of its Sudoku project is the ecological impact of these interventions. And again, whether the steroids use in every single patient with pneumonia down the lane, whether that make every kind of community member prone for more severe infections or even fungal infections, that's something need to be seen.
Yeah. That could well be the case. We don't know, and I'm not aware of any data to help answer that specific question. I guess coming back to CAPE-COD, my plea to the listeners of this podcast is CAPE-COD is a well-conducted trial by a very experienced group of researchers questioned the internal validity, but just think carefully about the external validity of this. Are your patients the patients that would have been recruited into this trial? And is your epidemiology similar to that of the patients in this trial? Because in other parts of the world with very different epidemiology, we may not see the same benefits, and we may well see other harms.
I think that's a good message to finish this interesting podcast. So thanks, Dr. Chacko, and thanks, Dr. Ian. I think it has been wonderful to chat with you on this controversy. And I think we probably, as you said, the conclusion is we are left with more questions than answers on this topic at this stage. So use steroids very cautiously, only if you need to.
Thanks, Swapnil. Thanks, Ian.
Thank you very much, Swapnil. Thank you, Jose. It's been a pleasure.
Thanks for listening to eCritCare Podcast. If you like what you just heard, we hope you'll pass along our web address, www.critcareedu.com.au, to your friends and colleagues. And please leave us a positive review on iTunes. Be sure to check out our archive section on our website for previous podcasts. Check us out on Facebook at Critical Care Education. Join us next time for another edition of eCritCare Podcast.